also maybe provide some clinical examples of how is it that we are using this clinical tool in the management of patients. So first of all, I have no disclosures. And for my first slide here, I wanted to share this important review that discusses organ injury in the setting of heart failure. And, you know, when we think about this, we usually focus much more on low cardiac output states, and this leading to tissue hypoperfusion and tissue ischemia. However, it is relatively frequent that we ignore the much more profound and much more prevalent adverse effects of increased central venous pressure and the transmission of this pressure into the abdominal organs, leading to congestive organ injury. For example, congestive hepatopathy with increased bilirubin, or the type 1 cardiorenal syndrome caused by a type of intracapsular tamponade. And so, you know, evaluating venous congestion becomes much more relevant in the setting of organ dysfunction, because being able to precisely assess the severity of this congestion can tell us whether this organ injury is likely to be caused by congestion itself or not. And so, as you all know, the first step in evaluating venous congestion using ultrasound, well, it's looking at the IVC. I'm sure you are all very familiar with this, so I'm not going to dwell too much on it. Here on the left, I show a normal IVC in both the long and short axis with a complete inspiratory collapse. And on the other side, here on the right, you can see a congestive or plethoric IVC with an increased diameter greater than 2 centimeters and with almost no to minimal respiratory variation. However, if you want to go beyond the IVC and actually evaluate the severity or grade the severity of venous congestion, you'll have to be able to analyze normal and abnormal patterns of flow in the central and peripheral veins. And so, for example, we all know, of course, flow in the arterial side is pulsatile, so we have a systolic and a diastolic pressure, and this pulsatile flow becomes attenuated as one moves further away from the left ventricle. And so attenuation of this pulsatility is a function of the aortic wall, because it has some distensibility, but it's also a function of the imposed resistance by the arterioles. And as such, it is normal that once we see the normal flow pattern in capillaries and venules, we will realize that this flow is continuous or non-pulsatile. Now, if we pay attention here to the end of this graph, we can see that the flow pattern in both the vena cava and the immediately adjacent great veins is actually also pulsatile. And the cause of this pulsatility, of this venous pulsatility, is secondary to changes in central venous pressure that occur, normally with the normal cardiac cycle. So, I mean, as you all know, we have the CVP waveform, in which we have an A wave that occurs during atrial contraction or atrial systole, a normal X descent, which occurs during right ventricular contraction or right ventricular systole, and a normal Y descent that happens during right ventricular relaxation or right ventricular diastole. And these changes in pressure are actually what results in a pulsatile flow in veins located at the immediate vicinity of the right atrium. So, for example, the hepatic vein. If you analyze the hepatic vein using Doppler, you will realize that its waveform is formed by two retrograde waves, the A and the V wave, and two antegrade waves, the S and or systolic wave, and the D or diastolic wave. Now, retrograde wave represents flow that is going from the heart to the liver, so actually backwards flow. And antegrade flow represents flow that's going from the liver to the heart, so normal venous return. And if you analyze the shape of this waveform, the hepatic vein waveform, you will realize that it is actually a mirror image of the CVP waveform. And this is because it actually happens at the same time. The hepatic vein A wave occurs at the same time as the CVP A wave, and both the hepatic S and D wave occur simultaneously with the X and Y descent, because they are caused by these pressure changes. And so the normal waveform in the hepatic vein, this is important to notice, has a larger amplitude of an S wave compared to the D wave. This is completely normal. Now, once you understand the origin of the hepatic vein waveform, it is easy to understand some relatively common abnormalities that we see with right heart pathology. So, for example, in the most left drawing, we can see a classic giant A and giant V waves that are frequently seen in patients with severe chronic pulmonary hypertension and right ventricular hypertrophy. Here in the middle, I show you a drawing of a lower amplitude of the S wave, and this can usually be seen in patients with moderate tricuspid regurgitation, but also in patients with systolic dysfunction of the right ventricle. And finally, here at the right, you can see a drawing showing a reversal of the S wave. And this is classic severe tricuspid regurgitation, in which a great proportion of the flow during ventricular systole is actually going back to the liver. So it creates this reverse S wave. And so, as you can notice, analyzing the flow pattern on the hepatic vein can actually give us a lot of information about the filling pattern of the right heart. However, it's important to notice that it does not give us a lot of information about its filling pressure. So only pattern, not pressure. Additionally, this backwards pressure from the CVP that gets transmitted to the hepatic vein, of course, it can also get transmitted backwards to the peripheral veins. However, as one gets further away from the right heart, this pressure will become attenuated and the flow will become less and less pulsatile. So for example, if you look at my flow pattern in my own femoral vein, here you can see that yes, it is pulsatile, however, it's not as pulsatile as my hepatic vein. And once we reach my popliteal vein, so very distally, the flow becomes continuous and non-pulsatile, okay? And now this pressure transmission that makes flow become pulsatile in the venous vascular tree is easily attenuated because in a healthy patient, our absolute venous pressure is not only low, but also we have a very high venous wall distensibility. And so pressure changes that come from the CVP get easily buffered by changes in venous volume. On the other hand, if we look at what happens in patients with severe venous congestion and heart failure, well, not only do they have an absolute increase in venous pressure, but also their veins are now fully distended and can no longer buffer these pressure changes coming from the CVP. And so pressure is easily transmitted from the right atrium to the peripheral veins, reaching the venules and might even reach the capillary beds. And we can see this happening in patients with chronic venous insufficiency. For example, if we look at patients with peripheral chronic venous insufficiency with severe disease like CF class 4, class 6, most of them or all of them will show a pulsatile flow on their saphenous vein, but this does not happen on healthy patients. So yes, evaluating pulsatile flow in peripheral veins of the lower extremities can give us information about what I call peripheral venous congestion. However, if you want to assess systemic venous congestion, that is congestion occurring in the setting of heart failure, one of the most useful veins to evaluate is actually the portal vein. And here is why. So as we saw before, normal retrograde pulsatile pressure from the CVP gets easily transmitted to the hepatic vein, and this causes pulsatile flow in the hepatic vein. However, this gets rapidly cushioned by the venous wall distensibility of the liver veins, and it also gets dissipated by the resistance opposed by this sinusoid or capillaries in the liver. And so by the time this pressure should reach the portal vein, it's no longer there. This pressure does not reach the portal vein. And this is what causes, or what explains that normal portal vein flow is actually non-pulsatile or continuous. So as you can see here, this is a normal patient with a normal hepatic vein flow that is absolutely pulsatile with an S greater than D wave. But if you look, this pressure is not transmitted to the portal vein through the hepatic sinusoid, and we have a continuous non-pulsatile flow. On the opposite side, if we see a patient with severe congestive heart failure, biventricular dysfunction, and severe venous congestion, well, we see this patient has first severe tricuspid regurgitation because he shows a reversal of the S wave, but also we can see how this pressure is easily transmitted through the hepatic sinusoid into the portal vein, causing pulsatile portal flow. And now the first time that pulsatile portal flow was described in patients with heart failure was actually in patients with tricuspid regurgitation. And this was back in 1990, and it was published in a radiology journal. So this was mostly an interesting radiological finding that the radiologists found in patients with heart failure. However, it took us almost 30 years to start using this tool at the bedside. So this pioneering work by the group of André Deneau in the Montreal Heart Institute, they used this tool in patients undergoing cardiac surgery. And they actually showed that altered portal venous flow was very correlated with the subsequent development of congestive injury or severe acute kidney injury. For example, here the hazard ratio for severe acute kidney injury in patients with increased portal venous flow pulsatility was 5.12. Not only that, but in the multivariate analysis, they showed that altered portal venous flow was an independent predictor of AKI and was one of the most important predictors. And so alterations in portal venous flow can be quantified using this pulsatility fraction. Here's the formula, just maximum velocity minus minimum velocity over maximum velocity. And we can classify, this is a little bit somewhat arbitrarily, but it's really helpful to use this classification. And we can classify this portal vein as a normal flow, which is continuous or non-pulsatile, or at least less than 30% pulsatility. Moderate congestion, where we see a pulsatility fraction greater than 30%, but less than 50%, and severe venous congestion, where we see greater than 50% pulsatility fraction. In this example, we're actually seeing greater than 100% pulsatility fraction, given flow in this example is actually negative in the portal vein. And so not only does portal vein pulsatility increases with congestive heart failure or with venous congestion, but also treatment to relieve these congestions, for example, diuretic treatment, can normalize flow in these patients. So this is actually a case series that has been recently accepted for publication, where we actually we evaluated patients presenting with cardiorenal syndrome to the emergency department. We actually had some patients with left heart failure, some patients with right heart failure, but we can see that all of them had increased portal venous pulsatility before treatment when they have acute kidney injury. And after decongestive treatment with diuretics, we were able to normalize portal venous flow in all of them. And importantly, this normalization of portal venous flow coincided with the return to baseline of serum creatinine. Also, importantly, if you look here at the right, you will see this graph that shows what happened to the IVC after decongestive therapy. So, of course, in patients with left heart failure, most of them after diuretic treatment, we were able to reach a normal IVC with normal inspiratory collapse. However, we did not observe this in patients with right heart failure. And this is important. This patient population of patients with right heart failure will almost all the time or almost always have a plethoric IVC. And so the IVC is not very useful for assessing and following these patients with venous congestion. And I think the portal vein is a much more useful tool in this patient population, not only to evaluate the presence of venous congestion, but also to monitor its changes during the congestive treatment. However, there are important caveats when using the portal vein. So, one of the most important of the false positives, we see a lot of portal vein pulsatility in healthy subjects with low BMI that have no heart failure and no venous congestion. So, for example, in this workshop that we do at our institution where we teach residents to perform this Vexus exam, it is very frequent that we use medical students as models. And they tend to be relatively young and healthy and thin, and so it's not infrequent that we see this is actually a portal vein from one of these medical students. We see portal vein pulsatility even greater than 50%. Of course, if you look further, this patient had a normal IVC with a normal inspiratory collapse, a normal hepatic vein, a normal heart. So then this is probably not related. This is definitely not related to venous congestion. On the other side, you could also see some false negatives. That means a normal non-pulsatile portal vein, even in the presence of severe right ventricular dysfunction and severe venous congestion. And this happens a lot in patients with chronic liver disease because of increased stiffness of the liver parenchyma and thus increased resistance to the transmission of pressure from the right atrium all the way through the liver sinusoid and to the portal vein. And so, because of these caveats, it is very important not, as any ultrasound or clinical finding, not to interpret the portal vein in isolation, but actually to try to use a multi-organ assessment to try to increase the specificity of the venous congestion exam. So another vein that's very useful to evaluate venous congestion is actually the intra-renal vein, or this could be the interlobar or the arcuate renal veins. And we do not use the parenchymal or principal renal vein because it's very close to the hepatic vein. Actually, its flow pattern is very similar to the hepatic vein. But if you actually go further to the intra-renal vein or parenchymal renal interlobar or arcuate veins, you will see that flow in these veins is actually fairly continuous, mildly, just slightly pulsatile. And this can be used to assess venous congestion. So importantly, to understand renal Doppler, it is important to notice that both veins and arteries actually run parallel to each other. So it's very frequent that when you use Doppler to interrogate the flow in one of these vessels, you will actually get flow from both the artery and the vein. However, given the direction of flow is opposite direction, you will usually see the arterial waveform above the baseline and the venous waveform below the baseline. So this is also the case for the intra-renal Doppler. So above the baseline, we see the arterial waveform, and below the baseline, we see the venous waveform. So now in this very important work by this Japanese group led by Noriko Ida, they actually evaluated these alterations in intra-renal venous flow that occur in patients with venous congestion and heart failure. And so they classified these alterations as normal, which means a slightly pulsatile but continuous venous flow here at the top. Moderate congestion, which is seen here as a biphasic flow. That means a flow that is interrupted in both systole and diastole. And finally, the severe degree of venous congestion can be seen with a monophasic pattern of flow, in which venous flow only occurs during one phase of the cardiac cycle. It can be either systole or diastole, and this is usually diastole. And using these classifications, these authors actually found a very strong association between altered patterns of intrarenal venous flow and adverse clinical outcomes in patients with congestive heart failure. And again, this highlights how organ congestion is probably an important factor in mediating morbidity and mortality in this patient population. So you can use multi-organ assessment, now that we've seen the IVC, the hepatic vein, the portal vein, and the intra-renal vein, to create a more specific score of venous congestion. We have called these the Vexus score, or the venous excess ultrasound score. And you can go all the way from 0, where there's a normal IVC and normal flow patterns in the hepatic, portal, and intra-renal veins, all the way to Vexus 3, where we have a plethoric IVC and severe alterations in the flow patterns of the hepatic, the portal, and the intra-renal vein. Now, this is a very recently published paper using this score, using this multi-organ assessment of venous congestion, also in the same group of patients undergoing cardiac surgery. It was shown to have increased specificity than each of its individual components, so better than the portal, hepatic, or renal vein by its own, but it also outperformed the CVP, the actual measurement on the CVP, and its predicting ability to detect acute kidney injury. And the fact that it outperformed the CVP, kind of highlights the fact that what matters for the development of congestive organ injury is not only the absolute CVP value, but also the transmission of this pressure all the way to the abdomen and to the abdominal organs. So I wanted to show this very recent paper published in the Indian Journal of Critical Care. It's a case series of patients with cardiorenal syndrome. And these authors showed that using this Vexus score, you can actually show a very good correlation between an improving Vexus score and in those patients who showed a resolving acute kidney injury, and also those patients that showed a decreasing fluid balance. So again, highlighting that this is probably the patient population where Vexus score is highly likely to bring, you know, an improved assessment of and improved care when following congestion in these patients. And so here's an actual real-life clinical example of how does it look when we perform a complete Vexus exam on a patient presenting with cardiorenal syndrome. So this was a patient with severe chronic pulmonary hypertension who presented with acute kidney injury, creatinine of 3.5. And at admission, the complete Vexus examination showed a plethoric IVC, a systolic reversal of the hepatic vein, and a portal vein pulsatility of greater than 100%. And you can see here a monophasic or very severe alteration in intrarenal venous flow. You know, the patient was hemodynamically stable. We tried to give him diuretics, but produced very little urine. And because of severe hyperkalemia, we called nephrology. We started hemodialysis. And after 2-liter ultrafiltration, we can see already an improvement on these venous alterations. So, you know, the IVC is still plethoric. That did not change. But we now do not see anymore the S reversal. We now see an S of lower amplitude than the D wave, a portal vein pulsatility that improved all the way to 45%, and now we see a biphasic flow on the intra-renal vein. So already much better. And then the patient started producing urine, and with the help of some IV Lasix, we could get the patient all the way to negative 15 liters. Creatinine came back to, you know, almost baseline. And final assessment, when I saw this patient in the clinic, you know, the IVC is persistently plethoric as this patient has chronic pulmonary hypertension. But now we have a normal hepatic vein waveform, a normal portal vein waveform with a continuous non-pulsatile flow. And, you know, it's still a little bit altered intrarenal flow with a biphasic pattern, but definitely much better than when we originally met this patient. And so how to perform this exam? For the hepatic and portal vein, you can use either the phased array. Okay, so you can use either the phased array probe or the curvilinear probe, and you can set your ultrasound machine to the abdominal settings, and you place this probe on the mid-axillary line. Here you will reveal the liver. You'll see this big hepatic vein, and you know, perpendicular to it, you will see the portal vein. You can use color flow to kind of visualize them better. The portal vein has a continuous red color flow, and the normal hepatic vein usually has this pulsatile blue flow on color Doppler. And so to get the actual waveform, one can select this portal vein pulsed wave Doppler button. You put the gate inside of the blood vessel, and you ask the patient to hold the breath, and then you press the button again, and you will get this, you know, nice hepatic vein waveform tracing, which is composed, you know, normally of the S, the D wave, and the A waves. You can do the same thing for the portal vein. Now you just set the gate inside of the portal vein, and you press the pulse wave Doppler button again, and here you see this is a normal patient with a normal portal vein waveform, just, you know, a little bit pulsatile, but this is less than 30% pulsatility, which is completely normal in a healthy patient. Now, for evaluating the intra-renal Doppler, you displace the probe a little bit posteriorly, and here you will reveal this long axis of the kidney. And here is where you perform the exam. But first, I would suggest to switch to renal mode, because this actually lowers the color scale to about 16 centimeters per second, and this allows me to see lower velocity flows. So here I'm showing the iliac vessels, and if you displace a little bit posteriorly, you will reveal these intra-renal vessels, which are the ones you want to evaluate. And so here you select a couple of arteries and veins that look good here. You ask the patient again to hold the breath, and you press the pulse wave Doppler button. And here you have a normal renal waveform with arterial waveform on the top and the normal venous waveform on the bottom. And this waveform is, you know, mildly pulsatile, slightly pulsatile, but still continuous and non-interrupted, which is considered normal. And so, you know, I wanted to go ahead and tackle some frequently asked questions that I have gotten when I've given this lecture previously. And I hope they will help you understand Vexus better and actually help you interpret these alterations better in the clinical setting. So, one of the most frequent questions we get is it worth it to Vexus a patient that has a normal IVC? And the answer is no, of course not. A patient with a normal IVC is very unlikely to have severe venous congestion or venous congestion. And so, if you go ahead and do Vexus and you find some alterations, it is most likely that they represent false positives rather than true venous congestion. Because the first step in venous congestion is actually a plethoric IVC. So the IVC could be thought of as a screening tool to detect the presence of venous congestion. And then, if you find it, then you can use the Vexus exam to further evaluate or graduate the degree or the severity of this congestion, okay? Well, can there be a systemic venous congestion, that means Vexus 3, with a normal lung ultrasound? Yes, this happens all the time. So, the lung ultrasound that evaluates B-line pattern mainly assesses left-sided congestion or pulmonary congestion. And yes, there can be abdominal or systemic venous congestion without pulmonary congestion. We see this a lot in patients with predominantly right-sided heart failure, or we can also see this in patients with biventricular dysfunction, but that have been chronically adapted and have increased pulmonary lymphatic function. And here's an example. This is a patient with severe chronic pulmonary hypertension and right ventricular dysfunction. You can see here the D sign and a dilated RV, but the left ventricular function is relatively preserved. And so this patient actually had a normal lung ultrasound with an A profile all across the board. And if we look at venous congestion, we see this patient had severe venous congestion as evidenced by a plethoric non-collapsing IVC, an alteration in hepatic vein flow. This is characterized by giant A waves, very common in pulmonary hypertension. And this pressure is being able to be transmitted all the way to the portal vein, causing increased pulsatility here greater than even 60%. So this patient had severe venous congestion without pulmonary congestion. Then how do you interpret Vexus in patients that have severe tricuspid regurgitation? And the same way. This is an example that can be useful. This is a patient with severe pulmonary hypertension, right ventricular dysfunction, and severe tricuspid regurgitation. And obviously, we're always going to see this systolic reversal on the hepatic vein. But when I saw this patient had, was not feeling great, had a lot of shortness of breath and, exceptional dyspnea. And when I evaluated the portal vein, it showed 100% pulsatility, so very compatible with severe venous congestion. So I decided to treat this patient carefully with diuretics. After treatment, patient actually felt much better. Obviously, I did not cure her pulmonary hypertension. This patient is practically palliative care patient, but the patient felt better. We did not cure the tricuspid regurgitation, of course, so there's persistent reversal of the S wave. However, we were able to normalize portal venous flow. And so, this can help you see how the portal vein can still be useful and can still be used to assess venous congestion, even in the presence of severe tricuspid regurgitation. Can you have a Vexus 3 or have severe venous congestion with a normal hepatic vein? And yes, this happens all the time. For example, if the filling pattern of the right heart is normal, then the hepatic vein is going to be normal, right? Independently of the filling pressures. So, this is a case I like a lot because this was a patient with severe heart failure with preserved ejection fraction, so left-sided heart disease, who actually did not come to the hospital because of the COVID pandemic. And he waited like a lot of months in his house, and he came to the hospital with over 30 kilograms above his usual weight. So he was severely volume overloaded, had severe venous congestion. As you can see, here, this is a plethoric, non-collapsible IVC, and also severe venous congestion shown by a portal vein pulsatility fraction of greater than 100%, and a biphasic pattern on the intra-renal venous Doppler. However, look at the hepatic vein. The hepatic vein is completely normal, normal S greater than D wave. And this is because the filling pattern on the RV in this patient is normal. However, the filling pressure is definitely increased. So this pressure can be easily transmitted all the way to the portal and the intra-renal veins. So we gave this patient a lot of IV diuretics, and after the patient lost about 25 to 30 kilograms of fluid weight, these alterations in portal and intra-renal veins actually normalized. Next question, does Vexus 3 means the patient needs diuretics? And definitely not. Vexus 3 means the patient has venous congestion. And so it's important not only to realize that patient has venous congestion, but to actually identify the cause. So certainly volume overload can cause venous congestion in patients with heart failure. This is frequent. However, not always. And some causes of venous congestion are not due to volume overload. For example, look at this case. This was a patient with severe venous congestion, but the cause of this patient congestion was actually a tamponade physiology. So look here, I'm showing the pericardial effusion, the diastolic collapse of the RV, and this physiology is leading to venous congestion as shown here, a plethoric non-collapsing IVC, an altered flow pattern on the hepatic vein, here shown as a reverse D wave, and this pressure is able to be transmitted all the way to the portal vein, causing greater than 50% pulsatility, and to the intra-renal veins, causing a monophasic pattern. Now, of course, the treatment of this patient was not Lasix. The treatment given this was a malignant pericardial effusion. This was a surgical pericardial window. And after the surgical treatment, you can see congestion completely resolved. So now we have a normal hepatic vein with a D wave and then normal A wave, and normal continuous non-pulsatile portal vein, and mildly slightly pulsatile intra-renal venous Doppler, which is completely normal because now it's not interrupted. So another question I get is Vexus validated in patients with sepsis? I mean, Vexus has been mainly studied in patients with heart failure, either heart surgery, congestive heart failure, right heart failure, pulmonary hypertension, but there's not a lot of data in patients with sepsis. However, very recently, I think this month or last month, this paper by Rory Spiegel was published, where he looked at these altered patterns of venous flow in a non-selected general ICU cohort. And he actually found an association between altered hepatic and portal venous flow and the eventual development of major advanced kidney events. And so the authors of this study actually conclude that the portal and hepatic veins can potentially identify patients at risk for renal injury, and that it is likely indicative of increased right atrial pressure. It could perhaps identify patients in whom fluid resuscitation should be limited or should be stopped. I would say it could even identify patients in who they have to be de-resuscitated. However, in order to make this conclusion, we definitely need further research in this patient population. So, as Vexus has been mainly studied in patients with heart failure, well, it's important to realize that you will always find this patient with congestive heart failure who will also happen to be septic. And I see no problem in using Vexus to evaluate venous congestion in this patient population. Finally, does Vexus give me more information than just looking at the IVC? And I think we discussed this a little bit previously, but I wanted to exemplify this with the two clinical cases. So these are two patients with heart failure and venous congestion, and patient A and patient B. And if you wanted to know which of these patients has a greater degree of venous congestion, it would be a little bit hard by just looking at the IVC alone. So, I mean, you could go by size. The IVC of patient A is definitely larger, 3.4 centimeters. The IVC of patient B is a little bit smaller, but you see that none of both patients' IVCs have actually some inspiratory collapse. So, I mean, there's definitely venous congestion. If you look at the portal vein, now you get a different story. The portal vein pulsatility in patient A is actually normal, less than 30%, so not severely congested, while the portal vein pulsatility in patient B is greater than 50%, so severe venous congestion. And this patient A was a patient with chronic pulmonary hypertension, severe pulmonary hypertension that was aggressively diuresed previously, and now presented orthostatic hypotension and acute kidney injury. And so, given portal vein pulsatility that's normal, we realized this was not congestive kidney injury, but rather probably related to overdiuresis. So we stopped diuretics, we gave a little bit of fluid. Actually, patient, improved very nicely. Patient B, on the other side, was your classic heart failure with preserved ejection fraction with type 1 cardiorenal syndrome. He also had acute kidney injury. And after IV Lasix, the patient improved very quickly and creatinine returned to baseline. And so I think this example can really exemplify how the portal vein can give additional useful clinical information in the management of patients with both CHF or with both heart failure and acute kidney injury. And I think this is true for most conditions in which the patient needs to have increased filling pressures in order to maintain cardiac output. So, we see this in tamponade, in restrictive cardiomyopathy, constrictive pericarditis, or right ventricular failure. Well, where this patient population will always have a plethoric, non-collapsing IVC. That's normal, that's the baseline. Very rarely can you diurese to a normal IVC. However, this means the IVC is not as useful to evaluate congestive organ injury. If one of these patients develops, for example, acute kidney injury, one of the best ways to know whether this worsening in renal function is due to congestion or not is to go ahead and perform the Vexus score to precisely grade the severity of congestion going from Vexus 0 to Vexus 3. The worse venous congestion, the more likely that organ dysfunction can be attributed to venous congestion itself. And finally, an additional advantage of performing the Vexus score is that it is done on the mid-axillary line. So as opposed to looking at the IVC through the subxiphoid window or doing an echo through the transthoracic echo, this can be easily done in patients, mechanically ventilated patients in the prone position. So you have easy access to their mid-axillary line where you can actually evaluate the IVC, albeit this is the lateral diameter and not the usual anterior-posterior diameter than one would get with the subxiphoid view. But then again, you have easy access to the liver and you can easily evaluate the hepatic, the portal vein, and if you displace a little bit posteriorly, you can also evaluate the intra-renal venous Doppler. So you can get a lot of information about venous congestion, even in mechanically ventilated patients who are in prone position without a lot of hassle. And well, I'm going to end my talk here. I hope you enjoyed, and I would be glad to answer any questions. I wanted to share this picture. This is our hospitals and one part of the Mexican National Institute of Health. This is where I work, and I'm very proud of it. And I would like to invite a lot of you guys to come here, and hopefully when we don't have any more COVID-19, but thank you for inviting me, and I hope you have enjoyed this talk.
It looks like there was one question early on in the chat regarding the improvement before and after decongestion. Do we know how many liters on average were these patients diuresed, or percentage decrease in body weight?
Yeah, so this is very, very variable. Patients with left heart failure usually come to the hospital very soon when they are congested because they have pulmonary symptoms. So they usually decongest after 5-6 liters in my experience, but this can vary a lot. I've seen patients that, like this patient I showed, that had 30 plus kilograms above his usual weight. So this is extremely variable, and it depends on whether this fluid is accumulated mainly intravascularly or the patient has a lot of lower extremity edema. I would say it's very variable. In my experience, it might take up to 15, 20, even 30 liters to fully decongest some of these patients.
Someone else asked how do you correlate elevated JVP with the Vexus score?
Yeah, so there's definitely a correlation. So if a patient has a higher Vexus score, he will surely have an elevated JVP. So, I mean, the JVP can be analyzed. You can analyze both the height of the water column, which will give you a very accurate measurement of the CVP, but also the pattern of the waveform. So these alterations are very similar to using the hepatic vein Doppler and looking at the IVC. However, I do not think the JVP is extremely useful to evaluate the severity or the degree of congestive organ injury, because I mean, as we showed, not even measuring the actual CVP, it's as precise in predicting congestive kidney injury as actually looking at the Vexus score. Because Vexus score is not only evaluating the absolute venous pressure, but also transmission of pressure to the organs. Normal JVP for persistent portal vein pulsatility. This should not happen. I mean, obviously, in very obese patients who maybe have 3 central lines and the neck examination is hard, then you might foolishly or erroneously think the JVP is normal, but it shouldn't happen. It shouldn't happen that a patient with venous congestion and a pulsatile portal vein have a normal JVP. Has the reproducibility of the score been assessed? And yes, in the work I showed by André Denot and most of the works by Ida, yes, they show a very good reproducibility between the investigators. Actually, William, which is the principal author, showed this. There's a really very little variation between practitioners. And also, this has been my experience. You know, I teach young residents and fellows who have very little actually overall ultrasound experience, and once they get a grip of it, which it could take about 1 to 2 weeks of performing this study consistently, they get pretty reproducible. So yes, this has been studied, and this is also my experience that this is a very reproducible exam. Why don't we use this as often in inpatient non-critical care patients? Will the echo IVC dilation and collapsibility be enough for us who don't have Vexus access right now? But I mean, yes, screening for venous congestion using the IVC can definitely diagnose, or it can definitely make you think of venous congestion. But as I said, to finally grade or evaluate the severity of this venous congestion and to actually have an idea of whether this venous congestion is causing congestive organ injury, you definitely need Vexus. I think many portable devices, as you asked, like the Butterfly, have color Doppler. They don't yet have pulse wave Doppler except on the vascular settings. But using color Doppler, you can actually get a pretty good feel about portal vein pulsatility. So, for example, if you don't have to do pulse wave Doppler to see that the portal vein is having a pulsatile color flow, and when it's really obvious, you can actually tell that using some portable devices like the Butterfly.
I think also, if you look, Dr. Corralate, who's speaking next, he refers to it as Vexus Light, correct? Isn't that his kind of term, where he doesn't do pulse wave, he just looks for direction of color flow? Yeah, that's true. Actually, I think this Vexus Light term was coined by Philippe Rolla, and yes, you can use it. I have a lot of colleagues that don't have access to a full POCUS machine with a pulse wave Doppler. They have their own Butterfly machines, and they send me a lot of images. And sometimes you can really easily tell whether this is a Vexus 3 or a Vexus 0. I mean, maybe it's harder to tell in the in-betweens. For instance, in your experience, how practical has been to get these measurements reliable? It's fairly easy. With some exceptions, patients with severe respiratory distress who are very tachypnic and who will not cooperate by holding or by doing a breath hold, this is impossible. So, I mean, you can try to catch the motion of the liver secondary to diaphragmatic respiration,
and try to align your gait so that it coincides with the vessel at end expiration. And then you just pulse it and hope that while the patient is breathing, it will give you enough cardiac cycles so that you can get some interpretation. And this can sometimes be done, especially if patient is tachycardic and it's not in severe respiratory distress. But if the patient is bradycardic, I mean, heart rate of 45, 50, then it becomes impossible. You think you're the coolest thing. Oh, great. Thanks, Vicky. I think I don't see any further questions.
But I have to say congratulations. Like, honestly, this is like, I think for all the students on the call, like using ultrasound is not just a question of, you know, looking for a picture. It's to understand every person's physiology is slightly different. And the cool thing, I think what Dr. Rios has done is to customize our right-sided physiology, right-sided heart physiology to ultrasound findings, which is just amazing. I think it's just, it just pushes this to a whole other level. Yes, we can be kind of blunt diagnosticians, but if we can be really sophisticated diagnosticians, I think we take much better care of our patients. So super, super work.
Yeah, absolutely. I agree 100%. And I think, I mean, as any clinical tool should be interpreted on the overall context of physiology and pathophysiology. And so this ability to look at alterations in venous flow can really give us a lot of information about what's going on with the patient's right heart. And eventually, as you start, understanding these alterations and putting in the right clinical context, you can really make important decisions about patient care, and really easy, really non-invasive. I think as this tool becomes increasingly more studied, we will start seeing, hopefully we'll see improved patient outcomes by using this tool.
One question I have, how specific are you when you're reporting these in terms of grade 0, 1, 2, and 3? In the original study that they published, they also have Vexus A, B, C, D, and E, which I could share that and pull that up. I mean, do you say that it's, let me see if I can share that. Would you say that this is a Vexus B grade 2, or do you just refer to it as grade 2? And are there any differences you found between grade 2s in A, B, or C?
I don't actually use the Vexus score like it is. I mean, this score was set out to validate or to predict the presence of acute kidney injury, but not necessarily does it correlate with the actual physiology of the patient and the actual degree of congestion. So, I believe you can have like I showed you, I can have a completely normal hepatic vein and a very positive portal vein. So I would call that a severe venous congestion. So I usually report the individual findings more than the score. So I say IVC is plethoric, normal pattern on the hepatic vein, a portal vein pulsatility of 70%, and a monophasic flow on the intra-renal venous Doppler. And then I will add a little assessment. So in the context of this patient that has chronic pulmonary hypertension and present with acute kidney injury, the most likely cause of this organ injury is probably venous congestion, and I would suggest careful diuresis. So I go ahead and give a little bit more information and not just report a number on the Vexus score.
I think there's now a question about overload versus redistribution.
Yeah, Vexus cannot distinguish between these two. So this is a clinical question. So if you have a patient with CHF that gradually starts gaining weight and it's eating a lot of salt, it's not taking enough diuretics, and now comes with congestive symptoms, it's probably related to volume overload. But the patient that acutely becomes ill and has venous congestion, I mean, this could very easily be pulmonary embolism. It could be cardiac tamponade, and just a redistribution. So, I mean, the clinical context, the clinical history of the patient would usually tell you what you're dealing with. But the fact that you now know that the patient has venous congestion makes it very unlikely especially if there's severe venous congestion, that the patient is going to improve with fluid loading.
Okay.
Yeah. Thank you, Dr. Moses. I totally agree. Less is more in detecting and being able to evaluate venous congestion in order to avoid continuous fluid bolus, especially in critical care patients, should definitely be an important application for Vexus. We're not there yet, but hopefully more studies in this patient population, critical care patients, can bring it to the next level.